walk tall. Yeah, walk on.
Spastic diplegia is a common presentation for an individual with cerebral palsy. Notable features within the gait cycle of an individual with spastic diplegia include slight hip flexion and adduction, knee flexion, and plantar flexion throughout gait. Overall, they have a very inefficient gait with high energy expenditure described as equinus and crouched. During initial contact, these patients tend to strike first with their toe, having an equinus gait instead of their heel. They maintain a flexed knee and adducted hip position, leading to a narrow base of support. In loading response, they have an anterior trunk lean to shift their weight forward. Also, instead of the typical eccentric contraction of the dorsiflexors, they maintain plantar flexion as their weight shifts. In mid-stance, the quads are working hard as they maintain a flexed knee position instead of utilizing the screw-home tactic seen in normal gait. At this point, one can clearly see coxivaris and genu valgus. For terminal stance, they demonstrate decreased hip extension and they never reach terminal knee extension, secondary to their hamstring spasticity. Pre-swing of normal gait consists of hip and knee extension with plantar flexion. However, for the spastic diplegic, they have increased knee flexion, decreased hip extension, and a plantar flexed ankle that is most often inverted. Initial swing in normal gait is where max hip and knee flexion occur along with push-off. In this patient population, we see trunk rotation used to initiate swing secondary to their poor push-off. While their ankle is in a plantar flexed position, the muscle is not being lengthened to facilitate a quality contraction for push-off. At initial swing, they have less knee flexion than you see in normal gait. In mid-swing, we continue to see trunk rotation combined with either vaulting or circumducting to help clear the toes. However, some toe drag still occurs. Normally, in terminal swing, you see the knee extend and the ankle dorsiflex as it prepares for heel strike. Instead, with spastic diplegia, we see a lack of knee extension and dorsiflexion. As the lower extremity finishes swing, there is insufficient eccentric control, and movement occurs mainly to momentum from trunk rotation. Along the kinetic chain, there are many areas of impairment to be addressed in this population. We have identified plantar flexor spasticity to be the most limiting. Additionally, treatment for this influences impairments further up the line since activities are done in a closed chain weight-bearing position. For this particular video, we conducted our treatments in a manner that would be appealing to a child. You will see that we incorporated the patient's mom into our therapy session. However, the basics of these exercises can readily be applied to any population without the appeals added for the pediatric population. The treatment we are seeing here utilized the wobble board to work the plantar flexors in a weight-bearing, lengthened position while simultaneously strengthening both the plantar flexors and the dorsiflexors. The patient begins by moving the board slowly in a medial-lateral direction, then in an anterior-posterior direction. Another spoof off this technique is the clock game, instructing the patient to move to various times on an invisible clock on the floor. The therapist helps guide the direction of the board with their feet, and they can provide approximation at the hips if necessary to aid in balance. In this treatment, the patient performs a step-up while the patient's mom holds a ball out for them to reach and grasp. This works to stretch the plantar flexors in a weight-bearing position. In the beginning, the patient may need some tactile cues from the therapist to encourage flat foot to achieve the desired stretch. The step-up component of this exercise helps to strengthen the plantar flexors, as we often forget that spastic muscles can be weak as well.